Good morning. Thank you very much for the invitation to contribute to this discussion, and thank you, Richard, for the invitation as well. The presentations so far have been fabulous, and they resonate really soundly with my day-to-day work as a medical administrator in Metro South, which is in Queensland, for those of you who don't know. The measurement and management of performance of doctors in the public system is not a topic that can be considered in isolation from the measurement and management of the organisation's performance and organisational achievement of strategic goals and key performance indicators. Consideration is also required of the broader clinical and corporate governance context and systems that exist to support the doctor and the organisation. I will, however, today focus on the performance measurement and management of individual doctors at my health service in Metro South Health and the preconditions or enablers required at an organisational level to allow this to be conducted successfully. And I'm going to illustrate our senior medical performance review process by way of a story about Dr. Tom and Dr. Kate. Dr. Tom is a staff specialist in the Department of Internal Medicine at our hospital. This is fictitious in case anyone's didn't get that bit, sorry. Just so you know. Dr. Tom's unit is undertaking senior medical performance reviews this month, and Dr. Tom has been a staff specialist at our hospital for 4 years, and this is his second SMPR. Dr. Tom is meeting with his director today, Dr. Kate, to go through the findings of the SMPR. Dr. Tom's a little nervous about the meeting. He's confident that his clinical performance is sound as he regularly looks at the Health Roundtable reports and attends the M&M and audit meetings, but does wonder about the multi-source feedback. Last time there was some feedback that he could do better in communicating with respect to his expectations and requirements regarding patient care to the other people in the team. He was a new consultant then and received some coaching and support from his director, Dr. Kate. He is now more comfortable in the consultant role and feels better able to communicate verbally and in writing, and he hopes this is reflected in the multi-source feedback. At the meeting, the first part of Dr. Tom's SMPR, Dr. Tom is aware this is a confidential process. Now at the meeting, Dr. Tom's first part of his SMPR document shows his top 5 discharged DRGs and notes they are consistent with his granted credentials and clinical scope of practice. And he's pleased to see that, as he expected, his average length of stay, his complication rates, infection rates and mortality rates are all within accepted for the reference for his unit. The report notes that he did have one formal complaint via the Office of the Minister for Health. It was a particularly difficult case with family members with opposing views regarding the appropriate pathway of care for their elderly mother. He and the registrar spent a lot of time with the family explaining the clinical situation and the options for care. The hospital complaints manager assisted him in drafting the response from the minister, and whilst one part of the family were still unhappy with the outcome, in his clinical opinion, the best outcome for the patient was achieved. The report notes that he hasn't had any medico-legal issues and that his attendance and contribution at morbidity and mortality meetings is satisfactory. The next part of the report is the multi-source feedback. Dr. Tom is aware that his director, his colleagues in internal medicine, his junior staff, the senior nurses on the ward and in outpatients, the physio on the ward, and the administrative staff in the home ward and in the department have all been asked to complete the feedback. And Dr. Tom is delighted to see that he has received acceptable ratings in all categories of the multi-source feedback, and is particularly pleased with the comments regarding his good communication and approachability. Dr. Tom is feeling relaxed now and enjoys the rest of the meeting where his previous 12 months' contribution to training and education are documented. He's been the lead support for the trainees sitting their exams, and he's presented at grand rounds. He has plans in the next 12 months to take up a formal position with the college, and he hasn't done any formal research in the past 12 months. However, he has done some quality audits. He is nominated for the Clinician Leadership Development Program, and with the support of his director, and he's aware that he will need to undertake a project as part of that year-long program. He has plans to attend a couple of conferences, but hasn't decided on which ones as yet. Finally, his mandatory training record is included, and he has completed all the requirements. Moving on to Dr. Kate. Dr. Kate is the Director of the Department of Internal Medicine at our hospital and is looking forward to the schedule of meetings to discuss the senior medical performance reviews with her senior staff. The first time Dr. Kate had to do these meetings, she was a little nervous about providing feedback, particularly where people's performance was less than satisfactory. She spent time with the Executive Director of Medical Services getting coaching about how to conduct the meetings and provide feedback. And the EDMS did offer to attend the meetings with her, but she had also just completed the Medical Leadership in Action program and was feeling confident she had the skills to conduct the meetings. On the whole, they went fairly well. The preparation meeting for the Senior Medical Performance Reviews with the SMPR Project Officer was very helpful, and Dr. Kate is thinking about developing some department-specific KPIs that she might include as part of the next lot of multi-source feedback. She's going to discuss this at the departmental meeting later in the month. Given the objectives of SMPR are ultimately about providing high quality and safe care to patients, and with that front of mind, Dr. Kate has found it possible to engage medical staff in continually reflecting and improving their performance. Dr. Tom is the first meeting of the day, and Dr. Tom joined them straight after getting his fellowship, and he has really matured as a consultant. His first SMPR was in his first year as being a consultant, and besides some minor issues with communication, which have been rectified, he's doing really well. So that's the story of Dr. Tom and Dr. Kate. Now, I suspect some of you are thinking I'm relaying enhancing medical staff performance and management nirvana, or perhaps for some of you this is also your experience of senior medical performance review. In Metro South Health, and particularly at the Princess Alexandra Hospital, which has 9 years' experience in conducting SMPR, this is reality. However, it wasn't always like this. It was difficult to start with. Dr. Richard Ashby, the now Chief Executive of Metro South Health, but then the Executive Director of Medical Services and Executive Director of the PA Hospital, spent a lot of time with the senior and visiting medical staff, the clinical and divisional directors. Time was spent explaining the rationale for SMPR and gaining the staff's trust regarding the objective of the process. The objective of SMPR is to enhance work performance and career development of employees by clarifying performance expectations, ensuring feedback and guidance on performance, and collaboratively identifying learning and development needs and objectives. And as you've seen, this is done through the provision of information which is multifaceted, reliable and valid, impartial and confidential. The senior medical staff leaders at PA were the first to undergo the SMPR process. A lot of time was spent coaching divisional and clinical directors in providing feedback and conducting the meetings. But as time has gone by, everyone has become so familiar with the process in giving feedback that the requirement to support them in the conduct of the meetings from the Executive Director of Medical Services or the divisional directors is minimal to nil. The process is administratively burdensome, and I acknowledge the continued efforts of the two officers who work in that unit, Michelle Winningham, King Gerke. And any organisation intent on undertaking such a process must invest in resourcing with the intention of permanently committing to the process. In 2016, 27 units across Metro South will conduct senior medical performance reviews. In terms of numbers, 850 senior medical performance reviews have been conducted, which covers greater than 90% of the eligible senior medical officers and visiting medical officers, and that's resulted in more than 15,000 peer reviews. 68% of staff who've had an SMPR said it would inform their practice, and there hasn't been a breach of confidentiality or a grievance raised regarding the conduct of the process. The multi-source feedback has generated the most activity and resulted in a small number of clinicians attending the Cognitive Institute to participate in communication programs. It's also identified some significant communication and teamwork concerns that required third-party intervention and informed ongoing performance management processes for some clinicians. The lessons learned from the implementation and ongoing management of SMPR are that executive and medical leadership is essential. You need to take time to build consensus to implement these processes. You need to keep it simple and don't reinvent the wheel, and any recommendations need to be achievable. So how do you get to individual performance and management and measurement nirvana? Well, it is through what is described by some as the black box of clinician engagement. The King's Fund in the United Kingdom, in its 2014 report, Improving NHS Care by Engaging Staff and Devolving Decision-Making, described the concept of engagement as a psychological state associated with feelings of commitment and loyalties to one's organisation and involvement in one's work. Engagement is at the centre of a set of causal relationships in which certain conditions affect employees' levels of engagement, which in turn affects their behaviour and consequently influences their overall performance. So what are the conditions that affect employees' level of engagement and required for highly engaged employees? Well, there are three broad areas that are covered by leadership, trust, integrity and culture, and employees' influence and voice. And the leadership characteristics associated with highly engaged staff are stability and consistency and longevity in the role. And in our case, we had a long-serving surgeon leader was the CEO until Dr. Ashby took over the role, who'd already been in the organisation for a number of years. There is some evidence from the United Kingdom and the United States that medical leadership at the chief executive level is consistent with higher performing organisations. Distributed leadership models work best, coaching leadership styles, and a focus on building consensus in favour of change and supporting staff at multiple levels to deliver it. Trust, integrity and culture. There is a need for staff to have confidence in the integrity of their leaders and the fairness of their organisation's procedures, and to feel valued and supported at work. And an important measure of the culture of an organisation is how the organisation responds when things go wrong. The employee's voice and influence. Staff are more engaged when they work in flatter hierarchies, as well as research showing that hospitals that give clinicians and staff greater autonomy deliver better care and higher productivity. The evidence demonstrates that highly engaged employees are healthier and happier, with lower levels of staff turnover and significantly lower levels of absenteeism. Highly engaged employees are more likely to deliver high-quality care. They make better use of resources and deliver better financial performance, and are more likely to think creatively and innovate at work. High engagement is positively correlated with better patient experience, and a larger proportion of patients reporting that they were treated with dignity and respect. And critically important, engaged staff are more likely to intervene to raise concerns about safety or address poor behaviours. In Metro South, we measure staff culture and engagement every 2 years through the use of staff surveying with Best Practice Australia, which is a private research company. And this has been in place across the entire workforce at PA since 2006. And in November 2015, we completed the second health service-wide survey. The results of the last survey demonstrate that medical staff across the health service are in a culture of ambition and some in a culture of success, which roughly translates into an anything is possible mentality, with lots of innovation and a strong sense of success and achievement, of which there are many examples across the HHS. Finally, I'd like to comment briefly on an area where I think there is opportunity for employers and colleges to come closer together. Bullying, harassment and discrimination, which has already been raised. The existence of these in the profession is unacceptable and in the workplace not tolerated. However, the surveys conducted by several colleges and 2 surveys recently conducted by ourselves in Metro South would suggest that this is our current reality. We know that staff who are feeling bullied and harassed are less engaged and may not intervene when patient safety is at risk. Junior staff who are bullied and harassed may not feel able to escalate concerns when patients are deteriorating. We cannot let bullying, harassment and discrimination stand between us and providing high quality and safe patient care. And this can only be addressed, in my opinion, through honest and enduring partnerships between professional bodies such as the colleges and health services. Thank you. Thank you for your attention.